If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, AGP in the UK. Today we're going to go through the interpretation, initial follow-up and management of adults presenting with a hepatitic pattern in the LFTs or liver function tests, always focusing on what is relevant in primary care only. This episode is based on the British Society of Gastroenterology guidelines on liver function tests. A link to it is in the episode description. Right, let's jump into it. We have to start by remembering that liver disease develops silently, and at earlier stages, liver enzymes may be normal. And if they're high, the degree of abnormality is not necessarily related to the severity of the underlying condition. We also need to remember that AST and ALT are enzymes present in the liver cells, and the levels increase in response to cell injury or death. ALT is considered more liver-specific, while AST is also present in skeletal, cardiac and smooth muscle, and so may be elevated in patients with an MI or myositis. An AST-ALT ratio greater than 1 is a non-invasive marker of liver fibrosis. In early liver disease, AST and ALT can be normal, but the high AST-ALT ratio is usually present even if both values are normal. So what should we do when confronted by abnormal LFTs? First of all, we should not think that the extent of abnormality of the LFTs correlates necessarily with the severity of the problem. Common conditions leading to chronic liver disease like non-alcoholic fatty liver disease and hepatitis C are frequently associated with only mild or moderate LFT abnormalities. Also, we should not think that the duration of the abnormal LFTs is a reflection of clinical significance. So repeating the LFTs, hoping that they will improve, is not necessarily the way to go. We need to remember that in many chronic liver diseases, such as hepatitis C and non-alcoholic fatty liver disease, the LFTs returning to normal do not necessarily imply the resolution of the disease. Therefore, the recommendation is that most patients with abnormal LFTs should have a full liver screen, irrespective of level and duration of the abnormality. What is a full liver screen? This should include an ultrasound scan, hepatitis B and C screening, an autoantibody screen, seroimmunoglobulins, both ferritin and transferrin saturation, and often a celiac screen, alpha-1 antitrypsin levels, and ceruloplasmin. And finally, let's remember that there are three common patterns of abnormal LFTs: an isolated raised bilirubin with otherwise normal liver tests, a cholestatic pattern, normally showing a high ALP or alkaline phosphatase and gamma-GT, and a hepatitic pattern with a raised ALT and AST, indicating hepatocellular injury, for example, viral hepatitis, non-alcoholic fatty liver disease, and alcohol-related liver disease. The hepatitic pattern is the section that we will concentrate on today. The three most common causes of liver disease are alcohol-related liver disease, non-alcoholic fatty liver disease, and viral hepatitis. How do we manage these patients? First of all, if there are signs of synthetic liver failure, like unexplained clinical jaundice, a low albumin or a high INR, or if there is suspicion of malignancy, for example because of weight loss or marked cholestasis, we should urgently refer or admit the patient. If the patient has a hepatitic picture with a high ALT and AST, the management will depend on the level of liver fibrosis, which we can estimate using non-invasive fibrosis markers. The majority of patients presenting with a hepatitic pattern will have either non-alcoholic fatty liver disease or alcohol-related liver disease. So let's start with non-alcoholic fatty liver disease. Following a liver scan for patients with non-alcoholic fatty liver disease or liver disease of unknown cause, we will estimate the risk of fibrosis using the FIB-4 or NAFLD fibrosis score. These scores have cutoff points for low, intermediate and high risk of fibrosis. If there's a low risk of advanced fibrosis, we will just manage the risk factors in primary care and reassess periodically generally every 2 to 5 years. In primary care, the treatment for non-alcoholic fatty liver disease is weight loss, alcohol advice, the reduction of cardiovascular risk, and the management of comorbidities. If the risk of fibrosis is intermediate, these patients should have second-line tests such as an enhanced liver fibrosis blood test, also known as an ELF test, or imaging such as a fibroscan or elastography. However, patients with very high scores representing high risk of fibrosis should be referred to hepatology without waiting to do an ELF test, fibroscan or elastography. Let's now look at alcohol-related liver disease. For patients with alcohol-related liver disease, we will assess their alcohol intake using the Audit-C or the full audit questionnaire if necessary. Depending on the severity of the alcohol intake, we will give them a brief intervention, refer them to alcohol services or hepatology for further investigations. The treatment of alcohol-related liver disease is to stop drinking harmfully, and for many this usually means complete abstinence. Weight loss sometimes also helps because there is a synergy between alcohol and obesity. For example, when the BMI is greater than 35, the risk of liver disease doubles for any given alcohol intake. But finally, what should we do if the patient has a hepatitic pattern with a high ALT and AST without an obvious cause? That is, when the liver screen is normal and there is no evidence of non-alcoholic fatty liver disease on ultrasound scan or excess alcohol. In these cases, we will need to re-examine the history to exclude potential drug-induced causes. Also, ultrasound is only sensitive for steatosis when hepatocytes are more than 30% steatotic. So patients with milder steatosis might have a normal ultrasound scan. So, if these patients are obese or have metabolic risk factors, and we suspect that they may still have non-alcoholic fatty liver disease despite the normal ultrasound scan, we should assess them in accordance with the non-alcoholic fatty liver disease pathway. But at the end of the day, if AST or ALT remain high without an obvious cause, we will need to refer them to secondary care for further investigations. So that is it, a review of abnormal LFTs with hepatitic pattern. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.